on a dashboard so it's something you can look at daily and say, oh, this is where we're at. It gives you a good idea. So I think as managers, you'll want to come up with what's important to you and ask your people, whether it's operations or finance, to put that in some kind of report format so you can see it regularly. You can measure yourself. Or you might be asked as a manager to produce those indicators for your senior management. Monthly operating report, that's who your audience is. I provide initially several examples that it really depends on who I was reporting to at the time. Because sometimes I'm reporting to senior management, sometimes I'm reporting to external investors, sometimes it's external auditors, it's the department heads. Sometimes I give my direct reports and I report on what we're doing because they deserve to know where we're at financially. But it really depends on who your message is going to be structured so it's meaningful to them. I don't give my board the same information I give my department heads. I don't give my department heads the same information I give to someone who we're trying to borrow money from. It all depends on what is. Look at what the message is, who you're talking to, and what the message is you want to provide. And then, like Mr. Martin mentioned, they had, what was a 90-day plan with the monthly operating report?
Action plan. Yeah.
Action plan, okay. It's important that it's not just information, because if it's just information, you forget about the next day. I kidded with my department heads. I went into their department, found my financial report for 3 months ago, a stack of papers. I said, what are you doing that over there? You should be working on that thing. So make it meaningful so that they'll use it. And as managers use it, you're given certain tools, and you're going to be given a wide range of tools, but you use your operating indicators or whatever report you get, find out what the meaning is, and make sure you use it to your advantage. We're going to go through a couple of these examples. Use the financial information. I don't want to be too redundant, but it's okay. Given some other things we've talked about, think of where you are with your career, where you want to be in your career. What uses do you have? Can you see having for financial information in your particular setting? I've been in all different spots, but what information do you want that would be meaningful to you? Any suggestions on that one? You're a physician, family practice. What kind of financial information do you want? Income statement? Okay. What use do you make of that?
Progressive.
Okay. Well, yeah, how would you use that for something, looking at something in the future?
Make changes to improve.
Okay. What kind of information would you want? I'm sorry to put you on the spot, but you're good. Physicians are an important part of healthcare, aren't they? What would you, as you're looking at your practice, what would you want to get to help you make a decision on what direction you go in the future? I'll give you a pretty broad question, but you think of some idea of a situation where you want financial information to help you make a decision, and what information would that be?
You mean specifically in some direction, in some department?
Well, are you in this, you're a private practice, or you're by hospital? Okay. Okay. Is it a group practice or is it a hospital practice?
It's a group practice.
Okay. As an example, one thing you probably face is the use of balancing your clinical practice with your hospital practice. Do you do hospital care too?
No, not as much.
Who do you refer to?
Her.
Okay. And specifically, if you have one of your patients you have to have hospitalized, who accepts, who doesn't admit over at Mount Vernon?
Hospitals.
Okay. Do you know what a hospitalist is? What is a hospitalist?
They're basically primary care physicians, but they only stay in the hospital. So they basically order all the necessary tests and stuff that a primary care physician would usually do, but they're only contracted with the hospital. They don't have outside group or anything.
Anybody else? What else about hospitals? It's an important concept. There are hospitals all over the place. What's the purpose of hospitals? I mean, when did they even come up? Why were they invented? what purpose they serve. Why doesn't the doctor go take care of his patient out in the clinic, and when they need to go in the hospital, why doesn't he follow the patient in the hospital, take care of him? He knows the patient, he knows their circumstances. Why would you ever give it to somebody who doesn't even know your patient?
It frees up the physician's time, so he's not having to go around the hospital. He can actually stay in his clinic and see the patient.
Is that a value to you?
Yes.
Is there a certain training that you have to have as a for outpatient practice versus inpatient practice?
Not as much.
Not as
Some
much.
special education.
What are most of the disciplines that the hospitals have, what kind of background they have? Are they private family practice, or they internal medicine?
Practice, so I do.
Respiratory. I worked with IPC. It's called IPC, the hospice company. They're based in California, and the man who started this company, Adam Singer, was a respiratory therapist, a pulmonary function doctor, and he started the hospice IPC, the hospice company, and now they're in I don't know how many states they're in, at least in a dozen states, and it was fascinating to know hospitalists. Basically, as has been said, a hospitalist is a physician. He's a family practice, internal medicine, pulmonary function, but he does not have an outside practice. He only practices in the hospital. When he has a patient, he accepts the patient from a primary care doctor, that becomes his patient until discharge, and it's up to him to send that patient back to his primary care doctor and say, okay, hospitalization's done, I come back to you, here's the condition of the patient, and the primary care doctor can follow up on. It's important for a physician to have that support, because in Fort Lavaca, we do not have hospitalists yet, but some of our doctors want that. And so they have to divide their time between clinic practice, which is pretty busy, and still finding time to make rounds a couple times a day and then go to the hospital. And it takes a lot of time for them to do that. So they'll come to us and say, okay, can't you hire us hospitalists so we don't have to do that? So we use the financial information. This is probably the second example I have on here. I'm sorry, it's not third. It's up here somewhere. Oh, I'm sorry, very first one, excuse me. Here's where you can use financial information, the impact of adding that hospitalist to your provider makes in the community. We want to do that, but for us to hire a hospitalist is going to cost us thousands and thousands and thousands of dollars. And some of the things we want to know is that by doing that, will we be able to get 1 or 2 more patient days per month, or per day, excuse me. Because the doctors will probably admit more, historically, we can document that. The doctor will be more prone to admit for care versus keeping on the outpatient, because he doesn't have to follow the patient inside. Or another situation, if we don't have a hospitalist, and DTAR Hospital in Victoria has it, we've got some of our doctors referring our patients up to DTAR that we'd rather take care of in Fort Lavaca. So they're getting our volume, our business, because we can't provide hospital services. So as we have to take that financial information and say, okay, we assume that we'll have 2 more patients per day. We assume the payer mix will improve, and from private pay to commercial pay, we assume our costs will be such and such to recruit hospitals to be there 24/7. Then we take that information and put together what we call a pro forma, or a financial projection, and then we either sell the program on that, or we say we can't afford to do it. And that's where we use financial information. That's a kind of a practical example. Another one, I'm using some things that are real life for us. Critical Access Hospital does not have to provide OB services. I've got a director of nursing who says that we should drop OB services because it's not necessarily profitable. It's not profitable. But there's the other side of it, us who are saying that's something the community needs. You affiliate with the hospital where you have your babies. You take your kids and you're still back to the hospital where you have. We've got staff who were born in our hospital. They've got all kinds of loyalty to us. We could drop an OB program, maybe make money off of dropping that program. So we have to go back in there and what kind of information do we look at? We look at patient data, we look at expenses, we look at the loss of revenue, we look at the payer mix. And we may have great revenue from delivery of babies, but the payer mix may be all Medicaid or may be all private pay. Doesn't do us any good. So these are things we look at, and we're evaluating this currently. Another program is our physical therapy program, real life situation. We contracted the provider to manage our physical therapy program. We hire out the therapists and aides and so forth, but he manages the program, he recruits, he does all that stuff. He passed away from cancer 2 months ago. So now we're in a position, we've got to decide, do we want to continue going ahead, contracting that out, do we want to bring that service inside these are practical decisions that you'll be faced with as operations managers. It may not be OB or may not be PT. It could be radiology, whether you buy that MRI machine, and if you acquire that, do you buy it outright? Do you lease it? Is it an operating lease or is it a long-term lease? I mean, these are things you need to face, you'll be facing, and you need that financial information. IT is big, but it's costly. We just went through some renovations with some of our IT program. We were to the point where it was about to collapse. And we had the choice of either investing hundreds of thousands of dollars to rebuild our whole infrastructure, which we didn't really have the cash to do, but weighed against what happens if it crashes. And we said we can't let it crash, we rebuild. But those are where you set priorities. And so in each of your areas, you're gonna have to face these opportunities. You're gonna be given choices, and you're gonna have limited resources, and you'll need financial information to fill that out. So as you think about your situation, where would you go to get that information? What information would you even ask for? And the more you are able to look at that and have an idea, the better you'll be prepared to make good financial decisions. Relate to your house, your home life. You know, if you want to buy a new house or rent a house or whatever, you got to look at priorities. Buy a new car, pay for an education, go back and get your doctorate, master's, or whatever. Those are huge decisions. You can relate that to your personal life, relate that to your hospital operations experience, and you'll see why that's so important. Proper staffing levels, productivity levels. I worked with Aurora Behavioral Health, and again, they were mostly in California. We had a couple hospitals out in Arizona. Behavioral health program, they put a lot of emphasis on productivity. We turned out so many productivity reports, but they would go down and measure, okay, if we have this type of in-house patient, based on their behavioral, based on their diagnosis, would have to staff at 1-to-1, 1-to-2, whatever. And we came up with productivity standards. So if we had so many patients here, we knew that would translate into X number of FTEs. If we had more than that, those FTEs, we were very effective and measure that. So again, these are opportunities you take: financial or personnel, HR information, salary information, whatever it is, and use those to manage your departments within. Again, what I'm trying to do is give you an idea of what you'll face, or have faced, or should face. If you haven't faced it yet, you ought to look around and see if you're missing out an opportunity to manage with better information. When we're facing now, you know, a cost of living, wage increases, they're touching. But we all want to, we work because we like to work, we also work because we need to work, we need to be compensated. And so when I'm trying to hire somebody, I'm competing with Formosa, big player, international, and compete with Alcoa or Dow Chemical or Detour Hospital. And so I need to make sure my rates are competitive. My accountant who just left me went from my job, and she had a good salary, I thought, and took a job with Cedric Coke, 20 miles from me, 20 miles from the hospital, and she's getting a lot more money than I can pay her. And so I have to look at, well, in this particular case, what would it cost me as a hospital for a 3% cost of living adjustment? That's not big bucks. That's just to try and keep us equal with the economy and the rising costs. But as a CFO or a CEO or a department head manager, I've got to say, how will that impact me? Can I afford to do it? Big decisions. But this is where financial information becomes very important to you. I hope as you progress in your careers, you'll reflect on how you use that information to make you a better manager and more effective. Financial planning, I won't go into that. I've got a slide here, the financial plan we did in 2011, never been done at the hospital. But we did a financial plan that said, okay, we lost $2 million last year. What are we going to do about it? Well, we did lose $2 million, and we had to do something about it. And so we put together a strategic plan, a financial plan of what we're going to do to get out of it. We're recruiting physicians, cutting costs. We went through a whole elaborate deal. We put some strategic points in there, and then we boiled that down to specifics. What will this person do in this position? What will the manager in radiology do? What will physician recruiting, how will we do that? We broke it down so it's very manageable. And then it becomes something that's meaningful. Then you go out with your department managers and sit down and say, what can you do to help us accomplish this goal? And they become part of that financial planning. You go to your board of directors and say, here's where we are, here's where we want to be, here's what we want support on. And you sell it to your board of managers. And hopefully they'll support you on that. And sometimes they won't, they'll have other ideas, that's okay. But then you've got to adapt to it. But financial planning is important. That's one of the items that was put on that board of trustees training thing. The investment policy, we have a limited investment policy because we don't have money to invest. But I came from Arizona Children's Hospital, a corporation in Phoenix, Arizona. When I got there, we had $8 million in cash. For that size of company, it's a lot of money. We had long-term care, we had acute care, we had a step-down unit for newborns. We had a skilled nursing facility, and we had $8 million in cash sitting in a bank, earning interest at less than 1%. Not very smart. I mean, so I quickly put together a board of investment program. The board of directors was very conservative, and at first they said, we'll never let you invest a dime in the stock market. And as we demonstrated successes, they got a little bit more risk accepting, very conservative no matter what, because that was a lot of money to invest. But we got permission to start an investment program. First month, I think we bought in $200,000 in interest earnings. That was a lot of money. They'd never seen that before. But you think of all the years they passed, the opportunity to invest wisely. Look at the opportunity we had. So investment policy is important because your board has to buy into it. You have to have financial advisors that buy into it to help you structure that. And it's important. Okay, reimbursement, we've talked a lot about that. Reimbursement by Medicare, Medicaid is critical to any hospital because it's such a big part of your population. Commercial insurance, managed care organizations, private pay, you can't say goodbye without on behalf of. But what do you do to incentivize them to pay you? We kind of talked about that. You offer cash discounts, you offer competitive prices to whatever your competition is at the road to Victoria. But you have to try and figure out ways to help them pay. Payment plans that are as user-friendly as they can be, and with strong collection policies, so when they don't pay, you have the best resource you can to go out and get someone else to convince them to pay. Again, that you have to be careful in such a sensitive area. You can't just go out like send Guido out there to insist on money. You have to do it the right way. The types of reimbursement, DRG, do you know what DRG is? Okay, what does that mean?
It treats it, you're reimbursed by the diagnosis, not each little part
Okay.
disease.
They come up with the standard rate for a DRG, whatever it is. They take that, take these groupings of diagnoses and say, okay, you've got this type of diagnosis if this is this group. And for that group of diagnoses, you should have an average length of stay of 3.2 days or whatever it might be. And the resources you use relate to that. You take that times your base rate, and that equals how much you'll be reimbursed. And so you might have a heart attack victim and whatever their length of stay, maybe a DRG of 6 days or whatever it is, I'm making that up. If you keep them 3 days and they are well and get them out of the hospital, you just made money on that DRG. If you keep them 10 days because they have some complications, you lost money on it. So it's basically up to the hospital to manage those patients efficiently based on their length of stay. There's a lot of jokes that went around when DRGs first came out. Your conditions are severe, but your DRG is not, so get out, type of stuff. You can't manage patients that way, but I mean, literally we're taking health care and making a business decisions on it. And unfortunately, that's what healthcare is about nowadays. So you have to learn about DRGs. That's how you're reimbursed and manage your care accordingly. They have clinical pathways for the nursing and physician staff to manage a patient with a certain diagnosis all the way from admission through discharge. There are certain standards and certain measurements they can use. Say, this patient's progressing as they should, or this one's accelerated, or this one has complications. But there's tools that we use to help manage those. Per diem, that's another way. They'll say, we'll pay $1,250 per day. We don't care what kind of patient you got there, but we know for an average that should be enough to pay for your costs. And that's where you can negotiate with the managed care company and say, no, I need $1,300 or whatever it is. That's only percentage charges. That's getting more extinct. Charges, they found that hospitals can set charge at any level. If you have a percentage charges reimbursement every time you raise your rates, which could be astronomical, they're going to be paying you more, but they're not. Your costs could stay the same. And there's a lot of different reimbursement methods, but it's important as managers, particularly as you manage a department or a hospital, you find out how your patients are being reimbursed there'll be a mixture. There's multiple payers out there, so you have to learn, if you get primarily Blue Cross or you're primarily Medicaid, find out what those are like, those reimbursement methods are, and manage your programs accordingly. It's the business decisions you'll have. Compliance, oh, I love it. I just put a few of these up here. There's so many compliance requirements, and they're good, they're effective, they're important, but they're paying the rear sometimes. There's a lot you have to do. As you're JACO certified, you've got joint commissions, the requirements. If you're not, you could, all of them will have Department of Justice Medicare billing. You'll have your HIPAA. You've probably heard about HIPAA. What's that all about? Just a quick nutshell. What's HIPAA? Privacy, yeah. If I call up and say, listen, my neighbor, I think might be in your hospital, can you tell me if Joe Smith is in the hospital? Can I tell him? Why not? It's my neighbor.
It's the patient's optional, whether or not they want the person to know.
Can I do that if my wife is in the hospital? My own wife, my own kid, I can't ask in the hospital?
They don't want you to know.
I'm sorry?
What if your wife doesn't want you to know?
And how do you know that I'm her husband or whatever?
Yeah.
The HIPAA is a very big thing, but it's very touchy, and there's a lot of ramifications to that. I've got the health and information systems reporting to my place, my responsibilities. We just had a significant thing. A patient requested their medical records, and one of our people sent out another patient's medical records to that person. Oh, oops, you don't do that. And so we had to go through and find out what information was sent, how extensive, was it just a name and birthday or whatever, was it a social security number? I mean, we had to go through the whole thing. We had to contact the person who received the wrong information and made sure they either returned it to us or certified they destroyed it. We had to send notification to the patient whose information went out incorrectly, say, we did a big oops here, and apologize, and say, here's what was disclosed, here's the ramifications. You're talking about identity theft. If I got someone else's social security number and I was a mean guy, I could use that real badly. So we chose to, it's not required as far as I'm aware. We were clear if it's required or not, so we erred on the safe side. We offered some identity theft protection policy for the patient whose information went out that shouldn't go out. And just different kinds of policies, and we picked one that was specifically related to medical records. So there's a lot of things that go on. You can't be too careful when it comes to HIPAA. A lot of requirements, a lot of penalties, and that's one of the things. False Claims Act, you can frequently read in trade magazines about hospitals that either are closed or close to closed. There was one not too long ago where I think there was 5 individual CEOs and CFOs up here in the Houston area that were convicted of False Claims Act. I don't remember the details, it's no one I know. But these guys were in prison because of they were able to document, the government was documenting their fighting false claims against the Medicare program. Upcoding, any diagnosis code it should be this, and you're saying it really is much higher with reimbursement purposes. To follow fighting claims on services that weren't provided at all. And these aren't necessarily mean, evil things. Sometimes those are mistakes, legitimate mistakes. But the government doesn't care about that. If they come in and find that you're processing false claims, you can be fined considerably. And so it takes a lot of due diligence on finance, on patient financial services, on your quality control people who are reviewing charts and records. You can chart audits. I mean, there's all kinds of measures in place. Those are important regulatory requirements, but that's vendor compliance. That's a big part of it. Related third-party transactions. I was with one hospital where one of our board members sold us all of our insurance policies. And every year I'd have to write something for the audit about, I had to have him sign related party transaction disclosure, and he had to testify to certain things. And so that's the big thing. If you have any type of related party transaction, you gotta make sure you define that, you distance yourself, you define how that related party can't influence your decisions as a manager. So compliance comes in many forms. Those are just a few examples. Manager, we're talking about. I'm going to say thank you, but I'm not going to stop yet. Sorry. This is a false alarm. First of all, let's go back to critical access hospitals. What do you remember about critical access hospitals? And whoever answered the first time can't answer this time. What makes it a critical access hospital? What are the qualifications?
cost-based reimbursement.
You get reimbursed a percent of your costs. It's a 101% of your costs, Medicare patients. That's the good side of it. What do you have to do to qualify for that? 25 beds or less? Okay, what else? 35 miles from the closest one. You guys are gonna pass the test, all right? What else? Rural area. Okay, what else? And by the way, there's some geographic things that can make that 35 miles down to 15 miles. Like if you're in a mountainous area, so you don't have the Port Lavaca to Victoria straight shot, you can't go off the road accidentally there. But if you live in a mountainous area, it can be as low as 15 miles because of the weather and the terrain and so forth. So there are some variations to that, but primarily is 35 miles. What else?
Average length of stay has to be 4 days or less.
Yeah. See if you pass the test on that one. I think it's the next slide. Okay, you get it. You have to have the 24-hour, 7 days a week ER service.
You got the rest.
Well, good. Let's take some of this information that I've given you. I'm going to talk about, I called it homework and projects. I don't know, I'm not going to say the whole homework, but maybe you want to do this yourself just to help you reinforce what you're learning. If you had to go through those acronyms, would you remember what relationship they had to use a healthcare manager? What they mean, what they stand for? Okay, let's conclude for you. Let's dish. What does that represent? Yeah, and based on your disproportionate share of Medicaid patients you see, we're reimbursed at a lower level. MOR, and operating report. What do you want as a manager to see in that to make it meaningful information to you? It's not just financial, it can be operational, it can be quality, it can be all kinds of things. IGT, intergovernmental transfer. Remember my example, we had to send $650,000, we got $7.2 back. Sounds like the Las Vegas deal, doesn't it? Payment limit, payment limits program's going away. It's being replaced by the waiver 1115, which is, oops, I didn't put that on there. Oh yes, waiver 1115 programs down there. So you'll hear a lot. In the state of Texas, it's going away. Other states have kept the upper payment limit program. In fact, we were talking with some consultants yesterday, and they were talking about how the upper payment limit program is being downsized considerably in terms of the reimbursement method. And they just looked at us and say, thank goodness you guys are going on the waiver 1115 program. You're not going to be subject to those cost cuts that the UPL program is. So there are some states in the United States that still be in an upper payment limit program, and they'll see that revenue source shrink considerably. I think they're saying up to 80% or something like that. It's huge. So that's something you have to be prepared to respond. It may not be your fault, but you have to produce net income, and you have to deal with it. So you understand the programs. HIPSA, UA, compensated care that you can see, that's a big one too. Again, that's where we got our magnitude in return for 650,000, so that's good. These other things are just things you can be familiar with. That makes you convert the conversational conversation with some of the terms that are used. Here's what I would suggest if you already wanted to think more about how finance can affect you as a manager, is to take a look at these items on here. You've got some examples back in the packet, right behind this one, I think. No, it's probably number 3. This one, just take a balance sheet. What does that say to you? What information do you want to have it talk to you about? I mean, these things should talk to you and tell you stories. What does that story tell you? How about an income statement? How about a cash flow statement? Look at those. As a manager, say, okay, first of all, you go out there and do some Googles and find out what the scans are for days of cash on hand. Find out where your hospital is at, where your company is at, where your hospital is at. Do you meet standards, or do you have reason to be concerned? Do you have concerns? What do you do as a manager to try to improve your cash on hand? The general ledger, except for just maybe 1 or 2 of us who care about general ledgers, it's good to be familiar with at least what the use is. Sit down with your accounting department and say, okay, show me my general ledger and show me what this means. And it makes more sense than you think. You've got certain journal entries always relate to payroll or accounts payable or whatever. And you can tell a story of what happened with your department expenses or revenue based on your general ledger. It doesn't hurt to sit down and find out what those are about. It makes you more effective as a manager. Your departmental profit loss statement, AP report, a payroll report, those are different reports. Understand what they mean and how you can use them as a manager, make you a better manager. You'll find yourself making wiser decisions, and ones that you don't have to apologize for later because you didn't think about such and such. You thought it through, you didn't have the information. You impressed people because of how you approach your decision making. Project number 3. Here I gave you some examples. No, I'm sorry. I keep forgetting what side I'm on. If you want a dashboard report for your operations, what information would you want on it? Where would you go to get that information? You could be a radiology director. You want to know how many MRIs you did that month, how many CT scans you did. What do you want to know? What are your costs? What are your costs of supplies per test or per procedure? And put it into dashboard reports. Find something to give you the information so you can manage your department. As a finance department, what do you think is important for them to? They may not know what questions to ask, so you try and feed them the information, what you think they need to know as a manager. So whichever side that we're on, finance or operations, these are important things. Fourth one, this is where I gave you some examples. I think I gave you an income statement, a balance sheet, trial balance report, national statement. Just take this home and just say, okay, if I was responsible for the hospital today, how would I use this information? What does it tell me? What difference does it make? What portion would I be looking at most significantly? Certain parts like your depreciation will change a lot unless you're buying a lot of equipment or retiring a lot of equipment. They'll tell you how, if you watch that type of information, though, it can tell you how old your plant is, how old your equipment is. And so cash-wise, you've got to start planning for replacing some equipment. If your depreciation is getting up close to the last year, property plant equipment. There's different ways to look at that. You can do a formula to find your average age of the plant. If it's getting up there, you better be paying attention to that. That's where replacing some things. And where am I going to get the money to do it? But there's certain things you can learn from each of these reports. And as you look at where you want to be in your operations career, pick out some of the things that you want to know and how you use this financial information to help you get there. And look, they all tell stories. It's just a matter of how you read the stories. This project is similar to that, but I didn't give you departmental expenses. But you can take that for the same. I'm trying to give you statistics in there for the hospital. There's still a lot of stories. Look at where you are. So the statistics are going up or down. Look at your admissions through ER as an example. That's a big number, but sometimes overlooked. You should be getting probably in the teens, 15 admissions per ER visit. If you've got an ER staff that's really paying attention, just averages will tell you that that should be the case. We're down 7 or 8% range, and we know where doctors are referring patients out to trauma centers or other places where by diagnosis, by treatment patterns, they could have stayed right there. That's money out the door for us. So we had to sit down with our ER staff and work with them on that. Those are things that you find on these statistical reports that can help get a feel for it. One number that I always will look at every month is where our length of stay is. Last year we got up close to 4%. I got real nervous. Those are things you're watching and you manage that. You can't tell a doctor to discharge a patient just because they have an average. They just have 10. That doctor's got to make that decision. But you can make them aware of using swing beds. You can use the observation status before they admit a patient. There's ways you can manage that stuff. But if you don't understand the statistics, you're not going to get much help to it. So you can do it on a departmental basis. The last project I think I had on here was, this happens to be fairly regularly. If you were given a project to develop a financial feasibility on, how would you approach that? And what kind of things would you be looking at? Like if I wanted to look at the profitability of a physical therapy program, the example they use, or hiring a hospitalist, what would you need as an operating manager to put together a story? Where would you turn? You get some statistics, probably from medical records. You go to finance and get some accounting information to finance revenue expenses, reductions in revenue. You go to your patient financial services. It's like find out what your payer mix is. And so if you have Medicare or Medicaid or whatever it is percentage-wise, you know how to gear develop your program. But if you are, as an operating manager, are given that challenge, and if you aren't given that challenge, don't be surprised. We're constantly looking at better ways to do things, and this is the kind of example of how you do it. what are you asked, and how would you develop the story to support it, your decision, your recommendation? And how would you use that information once you make that decision to monitor and control it? Once you make a recommendation and they decide, okay, well, hire a hospitalist, you need to be tracking that program, see if it's working or not, and watching that program as it progresses. If it doesn't, go back and revisit the assumptions and say, we assume this, but here's what happened, what can we do about it? Again, I think that financial information is so important to be able to manage any program well. With that, do you have any questions for me? Is there anything about finance I didn't answer that we can try and answer? I appreciate your participation tonight. I'm impressed. In some of the groups I've taught, they haven't contributed as much. I don't think they were in the same position you are in terms of your understanding of some of the financial things. I appreciate your contributions. I'm impressed you know a lot more than